All right. Well, I think it is at the top of the hour, 3 o'clock. So we are going to go ahead and get started. My name is Andrea Baer, and I'm the Executive Director here at Mended Hearts. And today is our second webinar in our new 2021 series of Beyond the Numbers. It's a lipid control webinar series. Today's topic is the deal with blood pressure. So before we get started on the presentation, I just want to give you a little bit of background on our organizations who are bringing you these webinars. Mended Hearts' mission is to inspire hope and improve the quality of life of patients and their families through ongoing peer-to-peer support, education, and advocacy. The National Lipid Association's mission is to enhance the practice of lipid management in clinical medicine. And the foundation of the National Lipid Association's mission is to improve the welfare of patients and families affected by cholesterol and triglyceride problems. The three organizations that you see here have come together and partnered to bring you this series and teaching you how to control your lipids. And we're very excited that this is our second year to be able to do this. Before we begin, all attendees are in listen-only mode. So if you cannot hear, hopefully you can read the screen right now that says, check your audio button on your computer to assure the sound is on. That's typically the issue that we have with people not being able to hear. If you have any questions, please type them in the Q&A box at any time during the presentation, because questions will be read after the presentation. We are not able to unmute people due to the size of our attendees, and so please type your question in the question and answer box. As a note, the presenter will not be able to answer any questions about you as a patient or a loved one specifically, because he is not your treating physician. The PDF version of the slides, as well as the recording of this presentation, will be available on the Mended Hearts website following the event. And I would like to introduce to you our wonderful speakers that we have with us today. We have Dr. Keith Ferdinand, who is an endowed chair in preventative cardiology and the professor of medicine at Tulane University School of Medicine in New Orleans. And as a patient representative, we have Mike Coleman, who is a longtime member of Mended Hearts and was featured in our Heartbeat magazine not too long ago with his story about controlling his blood pressure. I am, again, Andrea Baer, the Executive Director here at Mended Hearts. But before we get started, we want to do a couple of polls to see how much information you know about hypertension. So I am going to launch the first poll. This you should see on your screen. If you could answer this question, is what increases your chance of having high blood pressure? Being underweight, exercising too much, not enough salt, or low potassium? And I'll just give you just a couple of minutes to give the right answer. From the looks of it, you all are a smart bunch. We aren't fooling anybody with this question, Dr. Ferdinand.
Yeah.
Not one person is getting it wrong. That's great. All right, I think we can end that. Everybody knew the right answer, low potassium. Pretty smart, huh? All right. The next question maybe is a little harder. I'm going to launch this poll. What blood pressure reading is considered to be the starting level to define high blood pressure or hypertension? They all can't be easy ones. I'll give everybody just a moment. And I think we're going to probably talk about this today, right, Dr. Ferdinand?
There'll be some teaching.
That's great. All right. So I am going to go ahead and stop the polling. Hopefully everybody was able to vote. And here are the results. So what do we think, Dr. Ferdinand?
Well, we've changed the definition, and I'll go over why the definition was changed from 140/90 and above to 130/80 and above. So many people still have the older definition, but we'll clarify that.
Great. All right. Well, we've tested our knowledge, and so I am going to turn the baton over to you, and you should be able to pick it up here any second, and we can't wait to hear.
Got it. Well, thank you very much to the Mended Hearts, NLA, and the NLA Foundation. When we talk about high blood pressure, we're going to be discussing the most prevalent and powerful risk factor for cardiovascular disease. Now, the National Lipid Association deals, of course, with lipids. That's various forms of cholesterol, elevated triglycerides. And Mended Hearts deals not only with hypertension, but also with lipids and bypass surgery, angioplasty, all of the devices that are needed. But if you look across the community, one thing that causes probably more disability than anything else is poorly controlled blood pressure. So I welcome the opportunity to discuss this particular risk factor because for many of us, we under-recognize the importance of elevated pressure as a risk factor. Here are my conflicts. Nothing I'm going to speak about is related to any one particular product. So here are the objectives. These are the things that we're going to try to do today. We're going to discuss target organ damage and how high blood pressure can damage the various components of the body. We'll discuss lifestyle education, things that you don't necessarily need to do, but you should do to decrease the chances of having hypertension. And I'm going to also suggest that all of us look at self-measured blood pressure, not just waiting for the physician or the nurse practitioner to measure the blood pressure in the clinic. And then I'll summarize some of the best means we have to control blood pressure and improve outcomes. Mended Hearts, NLA Foundation are all targeting heart disease and stroke, the #1 cause of death in the United States. And even more importantly, perhaps we don't recognize this, but it's also the #1 cause of death in women. Of course, we should be concerned with breast cancer, but 10 times more women die from heart disease and stroke than from breast cancer. Now, we have what are called risk factors. A risk factor is something that increases your chances of having cardiovascular disease. On one side, we see the modifiable risk factors. These are things that you can do that change your risk. You can stop smoking. You can control your blood sugar and your cholesterol. You can lose weight. You can do physical activity and eat a more healthy diet. And then we have some risk factors that unfortunately are difficult to change, like your family history, increasing age, socioeconomic status. Male sex is listed as a risk factor, but remember, cardiovascular disease is the #1 cause of death, whether you're a male or a woman. Obstructive sleep apnea, and then stress. And we'll describe stress a little bit more later on when we do questions and answers. The Surgeon General of the United States, the previous Surgeon General, had a call to action to control hypertension. And here you see the multi-ethnic, multiracial, heterogeneous population that makes up America. And for all Americans, he wanted us to make sure that hypertension was a priority and that we ensure that we control blood pressure regardless of where you live, work, and play. And optimize care, meaning make the best care available for patients with hypertension. So here's the goals. Prioritize it as a national strategy, meaning that push hypertension as an important thing that we need to address. Work with the community, which is what we're doing. Mended Hearts is a grassroots organization. These are persons who have suffered or know someone who has suffered in their family from cardiovascular disease. And optimize patient care. One of the reasons I think these type of approaches are so important is because the informed patient can partner with his or her provider. You don't sit passively and let the doctor or the nurse tell you about your body. You say, what's my number? What was my blood sugar? What was my A1C? What was my LDL? And some providers are sometimes put off by that, but an empowered patient who's a partner in his or her care will have better outcomes. So now let's discuss what I call the target organ damage. When you have an arrow and you shoot it against the wall, you hit a target. That elevated blood pressure that we measure in the arm also pulsates throughout the body. It can affect the heart and cause left ventricular hypertrophy, an enlarged heart, coronary disease, AF, which is atrial fibrillation, CHF, congestive heart failure. That pulsatile pressure also damages the kidney, and along with diabetes can lead to end-stage renal disease where you need dialysis. It can damage the vessels in the legs, peripheral arterial disease. The eye is actually part of the brain, and the back of the eye is called the retina. Pathy means disease. So disease in the back of the eye related to diabetes, hypertension, or other conditions, including elevated lipids, can cause retinopathy. And the brain, hypertension is a leading cause of stroke. 2/3 of persons who have stroke have blood pressure elevation before they have the stroke. And notice also their TIAs, which are like small strokes, and dementia. Here's another cartoon that shows some of the same concepts, but I want to highlight something a little bit unique. We often say that older persons who are losing mental capacity have Alzheimer's disease, and certainly that is a very crippling and disabling condition. But many times what these persons are suffering are actually small, undetected strokes from uncontrolled hypertension. So we now know that hypertension can cause, of course, the massive stroke where you can't function, you lose your sight, you can't move part of your body, you no longer can speak. But many patients with aging will have small strokes and cognitive decline. Another thing I want to point out is especially some of our male patients say they don't want to take any medicines that cause sexual dysfunction. Well, hypertension itself damages the circulation in the groin and can affect sexual function in both men and women. And of course, although we're not dealing with heart disease and pregnancy as a topic today, I must point out that elevated blood pressure can cause toxemia of pregnancy with seizures and death, and also can lead to heart failure after the delivery of a child. So you should control blood pressure whether you're pregnant or not if you're a female. Now, one of the questions is, what's hypertension? And many of you said 140/90 and above. Well, you're not totally wrong, but we now use 130 and above as stage 1 hypertension. Now, why is that? If you look at persons who have 140/90 blood pressure, compared to people who have normal blood pressure, less than 120/80, by the time you get to 140/90 or above, you've already doubled your risk for a heart attack or stroke. So it doesn't make sense to wait for that arbitrary magic number of 140/90 before you begin treatment. The definition of high blood pressure or hypertension, therefore, should be 130/80 and above. Now, there's some trends, and unfortunately, the trends are not all good, related to high blood pressure. If you use that 130/80, it's found in almost 66% of persons who are 65 years in age. And if you look at non-Hispanic Black adults, almost 2/3, regardless whether it's a man or woman, African Americans have hypertension. And the last bullet point, and perhaps the most disconcerting, is that our control rates, getting that blood pressure down, is not going the right way. And in fact, we are losing about 10 percentage points in control rates over the last several years. So hypertension is not only a powerful and prevalent risk factor, but we're not doing as well as we should as a society. Let me discuss a special population, African Americans. We know that this particular cohort is at high risk for heart attacks. And indeed, one of the drivers of this increased risk in non-Hispanic Blacks are the rates of hypertension. These are data that show hypertension-related death rates. And if you look at that line, at the bottom, you see the years. This has been going on for decades. It's an unfortunate and unacceptable part of the healthcare landscape of the United States that we have these type of disparities, where Black patients, African Americans, have higher death rates related to hypertension. It's been persistent, and the COVID-19 crisis has kind of brought that to the head. Now, this is from the Million Hearts. The Million Hearts is an overarching governmental program that attempts to decrease by 1 million heart attacks and strokes. And they suggest when you look at African Americans as a high risk population, it increases the risk for dying from heart disease and stroke, both for men and women, 2 to 3 times more of risk of stroke, 4 times a risk of kidney failure related to hypertension, and premature death, which is twice that of other populations. This is another curve that shows end-stage renal disease, ESRD. These are persons who need dialysis. The yellow line are Black or African American patients. And again, these disabling, persistent disparities have been present for decades, with Black patients having higher rates of end-stage renal disease needing dialysis. If the population of the African American in the United States is 13 to 14%, if you look at those persons who are disabled on Medicare needing dialysis, it's almost a third of those patients appear to be non-Hispanic Black patients. You know, it's not just heart disease, but it's overall survival itself. This is what I call the white-Black death gap. This is not social science. This is not a bad tweet or a Facebook post. I'm talking about life itself. The shortest life expectancy being non-Hispanic Black males, having a gap, a white-Black death gap when compared to non-Hispanic white males, and Black females having a much shorter life expectancy than white females. In fact, the life expectancy of Black females is closer to that of non-Hispanic white males, such that being a Black female almost removes the protective effects of being female. How do you measure blood pressure? Well, this young lady, unfortunately, is not getting it done right. She's in the clinic, her back's not supported, she's sitting on the table, talking on the phone, somebody's put the cuff on top of the clothing, which is going to impair, her legs are crossed, she doesn't have her feet flat on the floor, and she certainly is talking and not actually paying attention to what she's doing. This will not give you an adequate, accurate blood pressure. This is a cartoon from CDC that actually shows what you should have. Usually I leave the room because the provider can stimulate what they call white coat syndrome and actually make the blood pressure higher, probably because of an anxiety reaction. But you should be sitting in a chair, back supported, feet on the floor, arm at heart level, bare arm, no eating, drinking, talking on a cell phone, or smoking. This cartoon comes from a coalition of the American Heart Association and American Heart Association called Target BP. You can go to that website and you'll see other diagrams, and they actually show you all the right things you should do in order to have your blood pressure measured accurately. Now, our guidelines, which come from the American College of Cardiology, American Heart Association, and other organizations, including National Lipid Association, will guide us on how to treat blood pressure and how to treat lipids. The high blood pressure guidelines suggest that we use out-of-office blood pressure, that patients learn how to measure their blood pressures themselves. Here in New Orleans at Tulane, I've done tens, if not hundreds, of virtual visits. And I actually tell my patients that they should get a good, valid blood pressure and learn how to take the blood pressure themselves. Indeed, it's a class 1A evidence, and this scientific statement suggests that self-measured blood pressure monitor be done at home in all patients. Now, what monitor do you use? Well, I'm not selling monitors and I have no conflicts here, but there is a website called validatebp.org in which you can go to this site, validatebp.org, and you can see pictures and prices and model numbers of various blood pressure devices. Some of them are less costly than others, which can give a valid blood pressure measurement. The wrist and the finger blood pressure machines are easy to use, but at this point, they're not considered validated. All right, let's first talk about lifestyle interventions. How do you treat blood pressure? Non-pharmacologic means that you do things to help control your blood pressure without any medication at all. The risk factors that increase the risk for high blood pressure include an unhealthy diet, overweight, lack of physical activity, too much salt, and not enough potassium. And all of you in the audience know that potassium is mainly found in fresh fruits and vegetables, that is good for the blood pressure, whereas salt found in prepared breads, processed meats, takeout foods, canned foods actually increases the risk for high blood pressure. The high strength evidence is that high sodium foods actually cause more hypertension. It may be one of the reasons African Americans have a higher rate, although we see high sodium intake across all populations in the United States. I'm from New Orleans, and there's something called the Southern diet. You know it when you see it. It's high in fried foods, organ meats, processed meats, a lot of egg dishes, fats, sugar-sweetened beverages. And this is a study called Regards. It's over 30,000 persons living in the United States, especially in the southeastern area. And they found that the high Southern diet had the largest impact on the hypertension difference between blacks and whites, both men and women. And if you look at that last bullet, it doesn't just cause an increase in hypertension, it also causes an increase in stroke, coronary heart disease, end-stage renal disease, chronic kidney disease, sepsis, cancer mortality, and cognitive decline. So certainly, we like patients to have tasty food preparation, but they need alternatives to some of the classic high sodium, high fat diets that increase the risk for hypertension and other conditions. The DASH diet was studied by the National Institutes of Health, and it suggested that foods that were high in potassium, fruits, vegetables, complex carbohydrates, low-fat dairy products may actually improve blood pressure control, and the DASH diet was found to be very effective for African Americans. This is from one of our sister organizations, the Association of Black Cardiologists. If you go to their website, it's at the top, ABCARDIO, abcardio.org. You can get a copy of this. This is a pamphlet that's plant-based diet. You don't have to necessarily be a vegan, but having more fresh fruits and vegetables in the diet is one of the means to control hypertension and overall cardiovascular disease. Now let's talk about some of the other things you can do besides diet. And I'm not going to go into great detail in all of these. I'll just point out, if you look at the bold part of the writing, some of the most important take-home points. Increased physical activity. Increased physical activity doesn't necessarily mean going to the gym, although not many of us have been able to go to the gym in the last year or so. This means walking, riding a bicycle, doing home activity, gardening. All of these things are increased physical activity. It gives a class 1A evidence in the guidelines. Consuming too much alcohol. How much is too much? Greater than 2 drinks for a man, greater than 1 standard drink for a woman, actually can elevate blood pressure. Again, class 1A evidence. Weight loss, done safely, not by any means necessary, but done safely, 1A. Healthy diet, 1A, including the DASH diet. Sodium reduction, 1A. And potassium, preferably in dietary modification versus potassium tablets, has been shown to help control blood pressure. In terms of physical activity, you don't have to do it all at one time. And very strenuous activity probably is not going to be the best way, especially for middle-aged and older persons who have not been doing anything. The recommendation is moderate activity. If you see the little cartoon, they show some of the various activities: cycling, swimming, walking the dog. Even if you have some sort of musculoskeletal disorder, you can still move in the wheelchair. And the last bullet shows the person bending over, tending to plants. So it doesn't have to be something very strenuous. It can be moderate activity. How much? 150 minutes a week. That's 30, 40 minutes most days of the week. And some light weight training 2 days a week. Again, nothing very heavy. If you then look at treating high blood pressure with medication, one of the first steps is to educate the person. And I actually use these pamphlets on a regular basis when I see patients. Remember, the educated patient is the empowered patient. And that's why we now have a new educational handout on blood pressure. You can get it by clicking in the chat box. It's validated, it's based on the guidelines, and it gives you a lot of the understanding of some of these magical numbers that we use in medicine, such as systolic blood pressure, which is the upper number. It's the force that the blood pressure makes against the arteries. And diastolic blood pressure, that's the lower number. That's the force in the arteries when the heart relaxes. But there's much more that you can find by going to the chat box and clicking on the link to get this new educational handout on high blood pressure. What's the goal for treatment? Well, less than 140/90 is the older goal. The new goal for high risk, middle age and older persons with diabetes, kidney disease is less than 130/80. Now, it should be done with caution and care. You don't rush to any one particular number, but no longer do we consider less than 140/90 adequate control for hypertension. What tests should your provider offer you before you get your treatment for high blood pressure? Well, you know, we as human beings don't come with one thing, we come with a multitude of conditions. So while you may have high blood pressure, you should also check fasting glucose for diabetes, complete blood count for some sort of anemia or blood loss, lipid profile, which is what the National Lipid Association and the National Lipid Foundation actually deal with. That's elevated cholesterol, which is another risk factor for cardiovascular disease. Get a serum creatinine and measure the glomerular filtration rate. That's the rate at which the kidneys filter out toxic waste. Check the various minerals in the body, sodium, potassium, calcium. Especially in middle-aged and older women, thyroid disease is very common. Get a thyroid-stimulating hormone, urinalysis for protein in the urine, and an electrocardiogram. Not necessarily because the person is having a heart attack, but to have a baseline so that they do present with chest pain later on in their care, you can compare the EKG or ECG and see if there have been any changes. Now, there are some optional tests. I'm a cardiologist. We do echocardiograms. They can be somewhat costly, but especially in patients with more severe hypertension or patients who have shortness of breath or other cardiac symptoms, an echocardiogram can give you a lot of information. Checking the uric acid will show a person who has a tendency towards gout, and urine albumin to creatinine ratio is a way of measuring if the person has blood vessel disease or kidney disease and doesn't really know it and has not manifested it at this point. Now, one of the main things, and we're going to get to the perspective from the patient, because remember, an empowered patient is needed to control all of the risk factors, and that includes hypertension. But one of the main things is adherence. Adherence means that you take the instructions from your provider, you take them seriously, and you do them on a regular basis. Medication probably should be given once daily. If it becomes very complicated, you can ask the doctor to combine the pills into combination pills rather than have a multitude of medications. Simplify the therapy. I like to have patients keep their pills at one spot, usually in the bathroom near your hygiene when you do your oral care. Brush your teeth, rinse, take the medications. It's a way in which the person can then not forget the medication. Some like to leave their pills right next to their bedstand. Whatever works for you is important to remember. Adherence is one of the markers for adequate blood pressure control. And then finally, it's not enough for just the doctor, the nurse practitioner, or the pharmacist. It's a combination. It's team-based care. It includes not only the health professions, but the patient, the office staff, friends, and relatives. So blood pressure control is one of the most important things we can do. I think it's important not to have the doctor playing with the electronic health record while you, the patient, sits there passively. The physician or the nurse practitioner should engage with you, sit and talk to you eye level, literacy appropriate, culturally appropriate language, using models and handouts, and explain to you what the numbers mean, what the goals are, and what the treatment suggested is for your blood pressure and your overall care. I want to close with one thing that we're doing in New Orleans. Our Healthy Heart Community Prevention has for many years dealt with things like checking for cholesterol and glucose and blood pressure. But we've also now included community influenza and coronavirus vaccination. Why is that? Patients who don't get vaccination often will die from these conditions. And patients who have heart disease, high cholesterol, chronic kidney disease, diabetes are more prone to complications both from the flu and from COVID-19. So in conclusion, we discussed high blood pressure. It's a continuous problem. It's a direct relationship between heart disease and stroke. You also have to consider the age of the person, diabetes, and other conditions like chronic kidney disease. But nevertheless, controlling hypertension is essential in order for us to live healthy, more functional lives. And it's not enough just to sit there passively, especially as the physician mumbles something in Latin and sends an electronic prescription. Team care is necessary for tight blood pressure control, especially in older patients. Medications are often needed, and sometimes more than one, but lifestyle, along with medications, is an important component of effective blood pressure treatment. The Healthy Heart Community Prevention Project does have a website. It's a nonprofit, Healthy Heart CPP.org. If you just Google Healthy Heart New Orleans, you probably can find some of our information on that particular website. And of course, this particular program is targeted at the patient to not only control their blood pressure, but their overall cardiovascular health. You can send questions in now, but you can go to Mended Hearts or the National Lipid Association and always find evidence-based, helpful information on how better to prevent heart attacks and strokes. Thank you very much for this opportunity. And I think Andre is going to take the poll questions.
I am, but while everybody's thinking about this, I wanted to introduce Mike Coleman as our patient representative. Mike, I want to give you some time to share your story and what you've done to help improve your health. And I know you have some questions for Dr. Ferdinand as well.
Thanks so much, Andrea and Dr. Ferdinand. It was an honor to hear that presentation. I learned so much in just hearing that information again and again. And sometimes we just have to keep hearing it, and it impresses us every time. So thank you. I wanted to talk a little bit about my story. I am a heart surgery survivor, and my experience began at the age, well, actually, I have come with a history of heart disease. My father and mother both had heart surgery. None of the men in my immediate family have ever lived beyond the age of 65. So my father passed, and 3 of my brothers have also passed prior to the age of 65 with heart disease. And one of the things that was related to that, each one of them suffered with some form of high blood pressure and high cholesterol numbers. To that end, when I was 48 years old, my primary care physician said, your cholesterol is slightly elevated, but we're going to put you on Lipitor now to try and hedge some of those numbers. We know that you have a family history. We know that it's probably going to increase as your age goes on. So I began treating my cholesterol at the age of 48 prior to having any other real symptoms associated with cardiovascular disease. Fast forward a couple of years, when I was 54 years old, I was diagnosed with a more severe form of cardiovascular disease. I actually had to get a bypass surgery. And my experience, like so many of the folks, was just happened to be going along and experienced a sharp pain. I went to the hospital, fortunately, when I experienced the pain, and found out that I had high blood pressure, something I had not been paying attention to. And again, ultimately, I started the process of trying to find out what things I needed to do. And along the way, and I stress this to everyone, along the way, I kept complaining to my cardiologist, my new cardiologist, gosh, I've got these pains. And the cardiologist says, well, all of our numbers, all of our tests that we're taking say that you're okay. But I said, doctor, that can't be. And I can remember on my, I just finished taking a nuclear stress test, and the cardiologist was going over the results with me. And of course, for those who know about heart disease, nuclear stress test is perhaps the gold standard for detecting what's going on inside our body. And I said, doctor, if you're telling me I'm fine, then why am I on a scale of 1 to 10? I'm at about a 7. And she said, okay, let's do one last test. Let's go into a cath procedure in which, again, as you know, they go in and insert some dye into your heart to actually look at the condition of your arteries and blood flow. And surprisingly, I found out that I did have blocked arteries and had to get a bypass procedure. After that, one of the things that I want to continue to say is that awakened me to one very important fact. I'm responsible for making sure that my doctor understands my condition. And I've got to communicate that to them in a way that they hear it. And if I don't, the consequences can be greater for me. And so with my cardiologist in that case, it was very important to just talk about what was going on with me. Again, as I had mentioned, my story continued on with, after my heart surgery, I wanted to find out what can I do to give back. I mean, heart disease is affecting my family. It's taking the men in my family. So I actually conducted some research in the area of heart disease, and I wanted to find out why men are not volunteering more to be volunteers and help other people going through the heart disease that comes into our lives. Often, like we see with Susan G. Coleman and other organizations where folks come together and they support people through the process. We call those folks peer support volunteers. So someone who's actually been through the process, helping someone understand what it's like. God bless Dr. Ferdinand and all the incredible physicians that we work with. But each one of them, very few of them have ever been on the other end of a cold scalpel. Very few of them have ever actually undergone the procedures that they care for and advocate for. So as peer support volunteers, and one of the things that Mended Hearts does is we've been through the process, so we know what it feels like. We know some of the quirks that come with having cardiovascular surgery. Also, at Mended Hearts, we work very closely with helping the caregivers understand how to take care of the patient. So Andrea, I kind of got off point there a little bit. I want to share that the most important thing about my journey, my understanding of heart disease, is Dr. Ferdinand mentioned. I've got a family history. My blood pressure was up. I was in a stressful position, and my weight was out of control, and I was pre-diabetic. So all the warning signals that I needed to, again, take a more aggressive approach on towards controlling.
Yeah, thank you so much for sharing your story. And I think it was really important that you were an active participant in your care. And I appreciate you being an advocate for that, because it's so important to really have that conversation with your doctor. So we have some questions in the Q&A section, and I am just going to put one more shout out. If anybody has any questions and they want to get answers either from Mike or Dr. Ferdinand, please feel free to put them in the Q&A boxes now. Dr. Ferdinand, I think the first question is for you. In hypertensive patients without diabetes, what is the risk for kidney disease related to hypertension? And you're muted, sorry.
We often say when looking at persons who go on to dialysis with end-stage renal disease that diabetes is the #1 cause. But it really is not that simple. 80% of persons who have type 2 diabetes, which we used to call adult onset, have hypertension. And especially within the African American population, hypertension is as powerful or even more powerful as a predictor of going on to end-stage renal disease as diabetes. So if you don't have diabetes and you just have isolated hypertension, you still are at increased risk of going on to end-stage renal disease. Now, you don't go from normal kidney function to dialysis overnight. The glomerular filtration rate, which on the lab slip is GFR, starts in the 80s and the 90s. As we get older, especially if your blood pressure is not controlled, it drops below 60. Then you have chronic kidney disease stage 3. Once you develop chronic kidney disease, if you don't control your blood pressure, the GFR will continue to decline such that you will go on to end-stage renal disease and dialysis probably after several years. But if you have very severe hypertension, it can happen somewhat quickly.
Great, thank you.
Dr.
Oh, go ahead, Mike.
Dr. Ferdinand, I was curious, how does stress affect our numbers?
Thanks for asking that, Mike. I said I was going to delineate that a little bit more, but I didn't want to go on too long with the lecture, but you gave me this opportunity. Stress clearly has an important factor related to cardiovascular disease, heart attacks and strokes. We used to know the old stories of the couple that lived together for decades. One dies and then subsequently another dies. And we as physicians actually thought that those were just stories. Now with electronic records and following patients more closely, clearly people who have death in the family, a spouse, a child, have increased risk for heart attacks and strokes. Also, just living in an environment where you're always under stress, whether or not be a spouse that's combating you, a battered woman, or if you live just in a neighborhood where gun violence and the threat of violence is an ongoing factor, all of these things can contribute. The reason we usually don't speak about them that much when we talk about the conventional risk factors, because it's difficult to measure stress and what its impact is. But clearly, Mike, people who are under intense stress have an increased risk for high blood pressure, heart attacks, and stroke.
Thank you.
Yeah, and Mike, did you have another question too? I think you did.
I did, and one of the things I wanted to follow up on, during the pandemic, I also came down with COVID-19, and thank goodness I survived it. But one of the things I'm trying to figure out now, I really just shut down. I picked up weight, got the COVID spread. Like so many of us, went up a size in my shirts. How do I'm kind of scared about coming back to life now that we're lowering some of these restrictions. How do I safely kind of emerge from this from a health standpoint?
You know, I'm glad you brought that up. I did mention COVID-19. And when I was discussing disparities related to heart disease and stroke, and I showed the white-black death gap, which is real, not social science, we saw the same thing with COVID-19. In fact, African Americans, it's expected, will lose overall 2.7 years of longevity compared to 0.8 years for the general population. So COVID-19 is also a cause of disparities of death and disability. I'm glad you survived, Mike. As you know, 550,000 of our fellow Americans did not survive this terrible pandemic. If a person has a history of heart disease, and especially if they're middle-aged and older, when I talked about physical activity, aerobic activity, I didn't mean for that person to get out and start running, cycling, doing something very strenuous. You can take a moderate leisurely pace. If you have not seen your physician, nurse practitioner, pharmacist, or other provider because we were in lockdown for almost a year, then I suggest that perhaps even before you start increasing your activity, you get some baseline blood tests for cholesterol, kidney function, glucose, electrolytes. If you have anything at all, get an EKG. And in some cases, especially if you're middle-aged and older, you have a history of heart disease, the doctor may suggest either a stress test or a nuclear stress test. Sometimes we don't do treadmill stress tests during a pandemic because we don't want people huffing and puffing, possibly spreading aerosols. But if you have any symptoms at all, there's always the possibility that you have new onset heart disease. I'd mentioned earlier that I'm here at Tulane in New Orleans, but I'm also a native of New Orleans. And after Hurricane Katrina, many people died from drowning, but there were also people who died from the intense stress and displacement with heart attacks, strokes, atrial fibrillation, and other complications. And we've seen this also with the tsunami in Japan, with earthquakes in Iran. After natural disasters, there's a second wave that comes on. Well, the reason I brought that up is because after this terrible pandemic, you're going to probably start seeing in the regular literature and news reports increased risk for heart attacks and strokes related to stress, but also related to the fact that many people postpone those preventive healthcare checks for a year.
So very, very true.
Yeah, kind of scary. So the next question is, controlling your blood pressure by weight reduction, will that help patients be able to stop medications? Will it reduce their need for medications? Can they do that through diet alone?
Weight reduction definitely will decrease blood pressure. And we know the weight loss surgery, the bariatric surgery, we now have studies that many of the patients can decrease the number of medications they have, and some may even stop the medicines. But I'm a little different from some of my fellow citizens. Medicines are not bad. It's which medicine to use for which patient at which dose. In fact, we're not simple animals. We're human beings with free choices. And one of our abilities is that we can lower our blood pressure with medicines. The placebo-controlled trials with hypertension have been done. A placebo-controlled trial means you take a group of people who have high blood pressure. One group takes medicines and the other group takes a sugar pill or placebo, and then you watch them. These were done in the 1960s and the 1970s. The groups that were in the placebo in one of the studies done on veterans, after 2 years, the persons on placebo had heart attacks, strokes, or 50% of them were dead. So I tell my patients, take your medicines. You can always decrease the medicines or simplify your medications, but simply jumping off medicines with the hope that through weight loss you won't need drugs just doesn't make good sense to me.
Great, thank you. Mike, the next question is for you. It's asking what kind of supports you put in place when you were going through this journey to become healthier and to deal with your heart issues.
What kind of support did I put in place?
What kind of support system did you, I guess you had referred to having a support system in place, and they were just curious as to what was that support system and what did it look like?
Absolutely. Well, the very first thing I did was go to a cardiac rehab, because that put me in a group of other individuals who'd also been through the process, and we were at the same stage in life, so we knew we could talk about what it feels like 4 or 5 weeks after the surgery, some of the aches and pains, and we formed a fellowship. Actually, 2 of my best friends I met at rehab, because we were in a different kind of group, and they will often say to me, Mike, I need to actually put my eyes on you because I need to see how you look. I hear you talking, but I actually need to see you. And heart patients know there's different ways that we look that are important. Having some accountability people in my life also, not only from the church, but also family members that say, hey, I need you to challenge me to make sure I'm taking my meds. I need you sometimes to come go for a walk with me. One of my biggest support mechanisms was I got 2 poodles, and they decided they were going to train me every day to go out for a walk, and that was very important. And most importantly, one of the things we talked about, or I learned, is I had to really get a clear understanding with my wife and understand, first of all, I had to stop blaming her for my problem. And my heart disease was something that I had to take control of. It wasn't her fault. But once we kind of got that understanding, she became, again, my best advocate, my best supporter in terms of staying on track.
Great, great. I love the idea of the poodles. So the next question is, what's the best time or most effective time of the day to take your blood pressure and cholesterol medications? And I guess maybe that could go for either you, Dr. Ferdinand. Is there a scientific way of the best time of day? And then Mike, what works best for you as a patient?
Let me let Mike go first. What do you find easier? What do you think is most effective for you to adhere to your medicines, Mike?
Well, I do have to take medicine in the morning and in the evening because my Lipitor is best taken in the evening. I think as most statins are what my pharmacist had recommended. So when I get up, I'll check my blood sugar and my blood pressure. And after that, somewhere within an hour of that, I'm taking my morning medications. And then that's somewhere between 6 and 8 o'clock in the morning. In the evening, I try and take my evening medications also between 6 p.m. and 8 p.m. So I'm looking at almost a 12-hour split between the medications, and that works well for me.
I don't think that's a bad idea at all. There are some studies that suggest there may be a benefit even with blood pressure medicines taken at night. And I'll tell you about those studies for 1 minute, then I'll give you my final answer. The reason they suggest that is when we wake up, there's an early morning surge. That's when your blood pressure goes up, your heart rate goes up, you become stimulated to awaken. It's at that time of the period, 5, 6 in the morning, that you have most of the heart attacks and strokes because the blood pressure elevates. And some doctors and other prescribers have suggested taking the medicine at night. Here's what I usually suggest. If you have a long-acting medication that lasts over 24 hours, if you take it in the morning, then you're home free. And I find that it's sometimes easier to remember to take all the medicines at one time in the morning. Make sure, however, that you have a long-acting formulation. For instance, metoprolol comes in metoprolol succinate, which is long-acting, or metoprolol tartrate, which is short-acting. So you really should ask your pharmacist and your prescriber, is this medicine something that's going to last throughout 24 hours, or do I have to take one in the morning, one at the night? But the way Mike describes it makes good sense. For some patients, taking everything in the morning, especially with long-acting medication, is one of the best paths so that they don't forget to take their medicines.
Great, thank you. Dr.
Andrea,
oh, go ahead.
Can I circle back real quick? I'm totally remiss if I don't mention the biggest support that I had in my recovery came from Mended Hearts. And I know that's a plug for the organization, but truly that group works to make sure to kind of help you get through the rough patches, not just a month or two, but a year or two later, because cardiovascular disease it's not a one and done situation. It continues, right, Doc?
Yeah, certainly, Mike. I agree with you. Organizations, patient organizations, professional organizations, getting the right information helps to empower patients. And I think this idea, I showed the little cartoon of the poor guy sitting there looking at his watch, the doctor's playing with the electronic health records. Electronic health records are wonderful, but too many times now we're treating the computer and not treating the patient.
Mm-hmm.
Yeah, absolutely. I agree. So the next question is for you, Dr. Ferdinand. The question is, after I started taking Farxiga to lower my A1C, my blood pressure dropped. Why is that?
What was the medication?
Farxiga.
So some of the medicines now that are used for diabetes have what they call cardiovascular effects on the heart and the blood vessels. The SGLT2 inhibitors, the ones that help you urinate out the excess glucose, and the GLP-1 agonists, the ones that help you use your own insulin, have now been shown to protect against heart attacks and strokes. You're going to hear a lot throughout the remainder of 2021 and maybe going into 2022 about diabetes medicines also helping to control blood pressure, heart attacks, heart failure, and chronic kidney disease. That's not true of some of the older medicines, but the newer medicines appear to have that extra bonus not only treating the blood sugar, but treating the cardiovascular disease that goes along with having diabetes.
Right. So we have a lot of really great questions, but a lot of them are surrounding lifestyle change before adding blood pressure medication. And how much time do you allow for patients to change their lifestyle? And do you have a registered dietitian, nutritionist in your office to help that?
In my previous cardiovascular center, I had my own registered dietitian. I'm now at an academic center. We have diabetes education classes. I will tell you, however, that I'm very strong on this idea that we don't consider drug therapy by itself adverse. Now, if a person is low risk, younger person, new onset hypertension, no history of heart disease, of course we should give 2, 3, or even 4 months of lifestyle modifications. If you're middle age and older, you have documented coronary artery calcium on a coronary artery scan. You have documented carotid lesions on an ultrasound of the neck. You've had angioplasty, stent, or bypass. In that particular case, I believe that it's important to recognize that the studies have already been done. Patients who control their blood pressure, control their lipids, especially the LDL cholesterol, control their glucose, have less heart attacks, strokes, and die. Clinical studies predict what's going to happen in the real world. And when a person has a very high risk status and they say, well, I don't want to take medicines, I'm going to do it naturally. Well, I understand that, but at that particular time, the horse is out of the barn, out of the pasture, and running down the road to the next county. They may need to take medications in order to control those risk factors. And then with appropriate lifestyle modification, diet, exercise, maybe you can decrease the pill burden. But medicines are not bad. We're human beings. We have the ability to modify our environment for the better, and medications help with that.
Dr. Ferdinand, I heard when I started my journey, a wise doctor said, medications are like shoes. When you try on a pair of shoes, the first pair is not always going to fit. But if you don't tell your doctor that something's not right with that medication, he or she can't help. So we as patients have to give you the feedback so that you can do what you do best.
Absolutely. And that's one of the problems with someone taking a blood pressure medication or a cholesterol medicine and saying, oh, I'm getting side effects, I'm just going to stop. No, you communicate with your prescriber. You communicate with your doctor, your nurse practitioner, your pharmacist. There are 125 antihypertensives. There are alternatives to various types of cholesterol-lowering medicines. So just because you may have a nuisance side effect or even a serious side effect with one medication doesn't mean that you take all of your medicines and throw them away. You just may find alternatives. I like the idea of the shoe, Mike, that you have to find which shoe fits best for you.
Mm-hmm.
Yeah, that's so great. So we're coming up on the hour, and I want to be respectful of everybody's time, but we have so many amazing questions. I think we have 2 more that I'd like to address. One is for you, Mike, or maybe for you, Dr. Ferdinand. It says, as Mike so eloquently conveyed, issues can creep up. Even if you have not been diagnosed with high blood pressure, as a heart patient, or how often should we regularly take our blood pressure at home? If we haven't been diagnosed yet, or, should we be doing it at home?
Validate bp.org, get a valid cuff. If you have a blood pressure at home and it's normal, then you probably can wait and do it once every 2 to 3 months. If you have hypertension and it's controlled, maybe you can only do it once a week or twice a month. But if your blood pressure is uncontrolled, then doing blood pressures at home, out of office blood pressure monitoring, will help you partner with your provider, help you partner with your doctor, nurse practitioner, or pharmacist to get that blood pressure less than 130/80. Remember, the trials have been done. The observation has been made. The higher the blood pressure, the greater the chance for heart disease, stroke, chronic kidney disease, heart failure, and death.
And the newer machines actually will transmit that data right to your healthcare provider.
Absolutely. We do that all the time through Bluetooth. We give an app to the patient. They can check their blood pressures at home. They don't have to bring in a little piece of paper with the numbers scribbled on that they can't even read anymore. We can actually see the home blood pressures done in real time. The validatebp.org site has those types of machines which will allow you to communicate directly. Now, one of the problems is that they're not reimbursed, and I think we need to work with Medicare and the private insurance to help patients who have low socioeconomic status get access to these devices. But if you can afford, get a good blood pressure cuff, empower yourself to be a partner in your care.
Right. And the final question, and this is, what's your experience, doctor, about with high blood pressure due to severe preeclampsia during pregnancy? Do you ever see people get off of the blood pressure medications afterwards? If they had been undiagnosed with high blood, not diagnosed before pregnancy?
I'm going to answer that, but I'm going to let Mike give his concluding remarks, and then I'll answer that question as the last question.
Well, for the sake of expediency, I would first just like to say it's been a pleasure just to be on board with this. This is very important. And each and every one of us that are on the call, take the chance to call at least one person and ask, have you checked your numbers? If you can do that, you've done an enormous amount of work. Thank you. Thank you for listening and joining us today.
Thank you.
Young women who have hypertension during pregnancy is called preeclampsia. If it goes on to cause seizures, it's called toxemia. And it actually can cause damage to the young woman and even death to the baby. Blood pressures can be controlled. In that particular case, we use some of the older medicines which have been found to be safe in pregnancy, and stay away from the ACE inhibitors and the angiotensin blockers, some of the newer medications. It does place the woman at risk even after the baby is delivered, similar to gestational diabetes places her at risk of developing diabetes. So if you have a strong family history and you develop elevated blood pressure, elevated glucose in pregnancy, then probably you're going to have to pay real great attention to your blood pressure and your blood sugar even after the baby is delivered, because you may develop fixed hypertension or a new onset diabetes.
Great. Thank you so much. So we're going to wrap this series up, or this session up, with 2 more poll questions. So please, everybody, join us for it. But I wanted to also remind you that next Tuesday, we will be having our 3rd in the series webinar, and we have another great webinar that's coming up talking about lipid control panels, or lipid panels, and how to read it and understand it. And we also have a patient representative joining us for that one as well. But what did we learn today with the high blood pressure, and what's the starting level to define high blood pressure and hypertension? And I think that everybody paid attention, doctor. Almost everybody is getting the right answer, which is great. We love to see that. That was kind of tricky because I think that they've changed the name or the definition from pre-hypertension to stage 1 hypertension. Is that correct?
That's correct. Stage 1 hypertension is what I was talking about.
Yeah, yeah. So I will go ahead and end and share the results of that poll. And so 94% of you got the answer right this time, which is so great. And I am going to launch the final poll, which is just based on today's participation in the webinar. What did you learn? Will you make changes? Share with us what you think. And Mike, final thoughts. What did you learn today?
More than I can cover in a minute's worth of time. Dr. Ferdinand really did put a lot of knowledge on my brain, and some things that I'm going to take forth. Most importantly, though, the importance of going back to my pharmacist and saying, what's the best time to take my medications? That's something I'm going to address right away.
Well, I just want to end by thanking everyone for joining us. We had another great webinar. The recording and the PDF version of the slides will be available on our website, as well as the handouts. And I will show that lots of people learned something new today that has inspired them to make changes. So Dr. Ferdinand, with that, thank you again. Mike, thank you. We appreciate it so much. And I just want to tell everybody out there, thank you again for joining us, and see you next week. Bye.